Hi, my name is Chris Bucciarelli. I'm one of the emergency medicine residents here at the University of Florida, and today we're going to be talking about the Rapid Arterial Occlusion Evaluation Score, or the RACE score. I'd like to give a special thanks to Dr. Van Dillen, as well as Dr. Muir, for helping provide some of the information on these slides. First, we're going to go over our objectives. There will be 4 of them. The first one is identifying the difference between large and small vessel occlusions. The second would be identifying the difference between a primary stroke center and a comprehensive stroke center. Third would be identifying the outcome differences between a primary stroke center and a comprehensive stroke center. And last, learning how to perform the Rapid Arterial Occlusion Evaluation, or RACE score. With regards to small and large vessel occlusions, there's actually been 4 recent studies that have evaluated the management of these. And the overall consensus of this is that large vessel occlusions really require endovascular intervention without delay. And in terms of the delay itself, or the timing, the median time for treatment for these within these studies was about 2 hours. So regarding large vessel occlusions, there's 3 major types. First, there's a middle cerebral artery, and the internal carotid artery occlusion, or the vertebral, or basilar artery occlusion. In terms of the anatomy, the circle in the middle there is essentially the circle of Willis, and you have the cerebral artery coming off laterally for that. You have the internal carotid going off medially, and then you have the vertebral and basilar arteries further down on that brain stem. Here's a coronal view, and this is essentially showing the MCA that would be coming off laterally. So regarding the middle cerebral artery, the symptoms that you're going to commonly see, but not limited to with this, would be paralysis of that contralateral face, arm, or leg. You can have sensory deficits also on the contralateral face, arm, or leg. You can have some visual field deficits, paralysis of the gaze on the opposite side, and also sometimes aphasia or dysarthria. Again, for this is going to be where the middle cerebral artery is coming off, and again laterally. To give you a better idea of the actual area of the cerebral artery, it's highlighted in red here, especially on the picture on the right. This would also be another image of generally the area that, if you were to have an occlusion of the middle cerebral artery, the area that would be affected from that. So it's a very large area or territory within the brain. Next, the internal carotid artery. So symptoms for this that are not limited to this, but again, you can see are partial and complete blindness in the contralateral eye, and possibly an absent pupillary light response. You can have contralateral hemianopsia as well, or hemiparesis, or hemisensory loss. And specific signs of left hemisphere ischemia include aphasia, while right hemisphere would be, if you had an ischemia in there, it could be with left visual spatial neglect or constructional apraxia. And again, here is where you're having that internal carotid artery come off. This is kind of another view of where the internal carotid artery is within the anatomy, and I think it's important to look at this because also you do have communications to the anterior cerebral artery, to the MCA or middle cerebral artery, and to the ophthalmic artery. And so I think the important thing with this is that if you do have an inclusion of this, again, it covers a lot of territory, and so you can have different presentations for this. So there's not going to be one cookie cutter presentation if you do have an occlusion in this area. Finally, the vertebral or basilar artery. And with this, you can have what's called intermittent or herald hemiparesis. And this could also kind of almost manifest, or could be, I should say, a TIA. These are really, really hard to diagnose because they can really present with anything. From ataxia, you can have some facial weakness or dysphonia or dysarthria, as well as some ocular involvement. But it also can be as mild as just a patient coming in with simple nausea, vomiting, and abdominal pain. So they're very, very challenging to truly diagnose. And And again, on the anatomy, here is where they're coming off. Kind of another view too for that vertebral artery, and is again just showing that it is going down the vertebral bodies there. For the basilar, this is another view, and the important thing with this is just showing that it does affect the cerebellum, so you can have some dysfunction. If this area is affected, you can have some dysfunction with balance. Alright, so the next thing that we're going to talk about is again looking at the small and large vessel occlusions. And interestingly enough, about 35 to 40% of ischemic strokes are considered large vessel. We talked about the three different major areas that we do consider to be large vessel. And this is a really important aspect here is the mortality rate. So with these, if you have an ICA occlusion, your mortality is 53%, MCA is 27%, and then basilar, oddly enough, is 89 to 90%, so very severe. Looking at IV therapy for the large vessel occlusion specifically, there are limitations for it, and the reason for that is that you have poor recanalization of the large vessels due to the slow flow. These are basically the breakdown of the rates themselves. So for the ICA, only 4%. MCA, depending on what territory, you have around 30%. And then basilar is only 4%. So again, with those high mortalities and having this low of success rate is very concerning and can be very dangerous. Hence why the endovascular revascularization is the way to go with these large vessel occlusions. Now to talk about the rapid arterial occlusion evaluation, or the RACE score. This was initially created because they wanted to develop and validate a simple pre-hospital stroke scale to predict the presence of large vessel occlusions in patients with acute stroke. And again, the reason why this was done is because they have been able to identify that large vessel occlusions did need more than just TPA. So this study actually looked retrospectively at stroke patients and what aspect of the NIH score scale that they scored positively for. Then they created a simpler scoring system that could be done quickly, in the field for these patients. Then they did a study where they actually asked medics to use this to identify the patients whom were high risk for the large vessel occlusions, and then take them to a comprehensive stroke center, and later matched up those RACE scores and actually did the diagnosis, or matched them up with the diagnosis after the radiographic and intervention testing was done. So in terms of the score itself, there's essentially 4 to 5 parts. First off is just assessing facial palsy. So that would be if they're having any facial droop at all, and you rate those as absent to mild or moderate to severe. Again, the NIH SS score does have essentially equivalent to that. The next would be arm motor function. So then what you're going to be looking at is if they're able to have strength and movement in that. And again, you're going to either say normal to mild, moderate, or severe in terms of its deficit. Same thing goes with the leg. So that would be, again, going mild, normal to mild, moderate, or severe in terms of its deficit. Next, depending on if there's right hemiparesis versus left, the first would be looking at an aphasia. So you would ask the patient to either close their eyes or to make a fist. And if they perform both of the tasks correctly, then they'd be getting a 0. If they perform only one, they'd get 1. And then obviously if they can't do either, then they'd be getting a 2. Next would be looking at agnosia. So the two things that you would be asking them there is whose arm is this? So you're pointing to their arm, the patient's arm. And then you also have the patient, or instructing the patient to lift both arms and clap. And these are essentially looking at higher functioning levels to see if there is any impairment. So again, if the patient recognizes the arm and the impairment, then he or she would get 0. If they're only able to do one, then they would get a 1. And if they were not able to do either, or did not recognize their own arm and then could not follow the command, then they would be getting a 2. This actually looks at the race score, our race scale, and if you look here at approximately 5 is kind of when you actually have the delineation of the ischemia, with the large vessel occlusions. So that was kind of considered the point is a 5 or higher, you would identify with an ischemia due to large vessel occlusion. Now this may over triage a little bit when it's put in effect, but that's okay because we'd rather have that be something that's a lot more sensitive in that we're getting more people to be evaluated quickly than if we were actually going to be missing someone. So the race scale results essentially showed a very strong correlation with the NIH SS scoring, which is the 14-point question scale that is done when you're doing a stroke eval actually in the hospital. And again, it was kind of deemed that 5 equal to or greater than 5 would be the point where that you would be concerned for that large vessel occlusion. And that actually had about a 85% sensitivity and 68% specificity. Again, the key thing here is that we're always about ruling out. So the negative predictive value of 94% is very good in that it's basically saying if your score or your race score is saying the person doesn't have the stroke, then there's a 94% chance that they really don't have it, which is what you want to do because you want to be able to rule out life-threatening issues. All right, and so in summary of this, the race scale is simply is a very simple tool that has a high predictive value for the presence of a large arterial occlusion in patients suspicious for an acute stroke. And again, like I said before, has a very high sensitivity and good specificity to identify the large vessel occlusions. So moving forward, what are our plans? One is we'd like to introduce the race scale into the Alachua County and begin scoring all patients or all stroke patients with this. We also want to then correlate our race scales with our diagnosis in our stroke patients to see how similar they are. We like this to be done both going from North Florida as well as Shands. And finally, after the data analysis, we will decide whether using this scale is ideal for our region and our patient population specifically.